Hey, this is Matt Hartman coming to you from Pittsburgh, PA. I'm working today with Davin, who's a third-year med student, and we will be talking about neuroradiology and resources available for med students and interns. Again, the building blocks. Tremendous resources on here. It's part of the ACR. And here's a QR code to access that. You can get a free membership and then start accessing all of the resources. For neuroradiology, there's a ton. We have the anatomy, head and neck, and as well as a clinical neuroradiology primer. And we have some Anki flashcards there as well. RadPath, which is my favorite. We have special sections for brain and spinal cord. And then there's also an approach to reading head CT, C-spine, brain MRI. And we have some associated YouTube videos for some of those topics. So the RadPath channel, again, here's a plug for that, but the neuro, brain, and the spine are especially well done. There's some great RadPath on there. And if you like Anki cards, we have the RadPath flashcards available for you. So I'm a body imager. I'm not a neuroradiologist, but I love RadPath. I loved neuroradiology when I was doing it, and I will be going over some of the key concepts and things that I remember as a medical student and resident. So hopefully that will help you. And the target audience is someone who is doing a neuro clerkship, someone who might be doing neuroradiology for a day on a radiology rotation, or a future intern that wants to know something about the brain and spinal cord. So we will go over the tools at your disposal to study the brain and spinal cord, when to use them, and then go over some algorithms for some common diagnostic scenarios. So realize what I'm trying to do is summarize 70 slides from that actual building block presentation. I can't do it all, so I'm picking some of the highlights, and then I'm going to share some of my pearls, and then Davin will be going over an example scenario. So how do we study the brain? Well, CT, MRI are going to be our two workhorses. And of course, doing the vascular imaging using ultrasound, CTA, or MRA. And like anything in radiology, there's always procedures, which makes radiology a lot of fun from my standpoint. So let's start with CT. And this is one of the key things I want to get through to you, is that on CT, the bones will be white. And you can watch one of the intro lectures about imaging. But that is a key concept. Bones will be bright on CT, and then we can do windowing. We'll talk a little bit more about this, but if we want to look at the bony detail, look at the sinuses, the mastoids, you want to switch out to the bone window. If you want to look at the brain detail, brain window, and there's some special windows if you're worried about hemorrhage. So to understand that, we have to understand Hounsfield units, and Hounsfield units range from -1,000 for air to +1,000 for bone. And water set at 0. Fat will be -100, and blood will be around 50. You might be saying, who is this Hounsfield guy? Well, he won the Nobel Prize for this discovery, basically the invention of the CT scan. And this was, believe it or not, the first CT scan that was, this was revolutionary when it came out. We look at it now and say, what were you actually looking at? But first time being able to look at the brain parenchyma inside the skull. And there is an interesting story with how the Beatles funded this research, which you can look at on your own. So let's talk about CT. This is going to be the workhorse in the ER. Great for trauma. Working up a stroke, you want to know, is there a hemorrhage or not? Looking for complications, hydrocephalus, mass effect. Lets you look at the bones again, maybe there's sinusitis. It's cheap, quick, and again, gives you that information. Is there blood in the brain? That will make a huge difference for your algorithm if you have a stroke patient. Now realize that there is radiation and not as good of resolution as MRI, as we will see. So it is great for those complications: hemorrhage, herniation, hydrocephalus, and large vessel infarcts. And again, MRI will be more sensitive for picking up an acute infarct, but for these large ones, we'll pick it up on CT, but not as quickly as MRI. So MRI is using magnetic field, and we're going to use the hydrogen spin, basically putting the patient in a magnet 1.5 or 3 Tesla. The hydrogen spins are either going up or down, then you shoot a radio wave at it. And basically, if you have the hydrogen on water, you have the hydrogen on fat, proteins, tumor, whatever, will interact differently, whether it's hitting a hydrogen on water, hydrogen on fat, and that will give our contrast resolution. A lot of complicated physics in there, but just realize we're using the hydrogen spin in a magnet and then looking at the local environment. And we will then learn the sequences. Now note, the bones will be hypointense, and that's how we are describing everything with MRI: intensity. So the bones are hypo. You might think that's the bone, that's actually the fat. The bone is right there, hypointense. We're going to learn T2H2O. CSF is T2 hyperintense, T1 hypointense. We will give contrast, gadolinium, and this is detected on our T1 sequences. Then we'll learn about diffusion, which is great for acute strokes, and then flare. We'll talk a little bit more about that. It's great for inflammation. So T1, CSF dark or hypointense, T2, T2H2O, T2 hyperintense. We get the edema there. And then I told you we learn about flare. It stands for fluid attenuation inversion recovery. Basically, anything that's 100% water gets negated will be hypointense, and places you have edema, not 100% water, but maybe like 50-50, shows up very hyperintense. And this is great anytime there's inflammation, and really good for MS, multiple sclerosis. So MRI is fantastic. Lots of conditions, lots of great anatomic detail. The disadvantage: more expensive, takes longer. Patients who have contraindications, such as claustrophobia, might not tolerate the MRI very well. And then, of course, I want everyone to do the MR safety module. If you have any metal in your eyes, here in Pittsburgh, we have a lot of steel workers, have to tell patients that if they get metal fragments in their eyes, that's not a good idea to be an MR scanner, and we will have to do a CT instead. So MRI, great for tumor, infection, stroke, epilepsy, workups. Okay, now these are my pearls. So a summary of everything I've learned throughout my learning and teaching experience, and I hope you guys like these. So we went over the repetition's the secret. So CT, the bones will be bright. On MRI, the bones are hypointense. And again, you might look, I remember being a 4th-year med student looking at this and thinking that was a CT scan. Say, hey, the bones are bright, but that's actually the fat. The bone is the hypointense rim, just deep to that. And then we give the contrast with the T1, gadolinium. We went over Hounsfield units again. I cannot stress the importance of this. I'm going to tell you most, I shouldn't say most, but a lot of interns who have never taken our course, a lot of house officers are not familiar with the topic of Hounsfield units, but it's pretty simple. It goes from -1,000 to 1,000, air to bone, and water is 0. And we'll be looking a lot for blood, anywhere at 25 to 50 Hounsfield units. And then the windowing. So all we're doing is changing the grayscale. If we want the negative numbers for the lung, we get the great lung detail. If you want the higher bone detail, now you can make out the bone cortex from the medulla. And in the brain, we use this a lot. Again, this is our bone window. We can look at the sinuses, the mastoid cells, and if we want the brain window, we can make out the white and gray matter here. MRI. We talked about this a little bit already, but this is the down and dirty. Use diffusion for stroke. I go over this in the rad path video for neuro. I use a snow globe analogy. If we're worried about tumors, we need to give contrast, a T1 with contrast. And if you're worried about inflammation like multiple sclerosis, we use that flare sequence we talked about. And just to review this, T2H2O, CSF will be T2 hyperintense on T2. And then the flare is just like it, but you negate anything that's 100% water. But we have our edema here. And I think the edema shows up better on the flare than it did the T2. Intracranial hemorrhage. This is what we want to pick up on our CT scan. A trauma patient, someone with altered mental status, quick and easy to make the diagnosis. So epidural, this will be extraaxial collection, sort of bilobed, usually a trauma patient. Subdural, also extraaxial, but crescent shape. Usually our older patients, maybe slight trauma, disruption of the bridging veins, get these subdural hematomas. Again, we're looking for complications like some mass effect. Subarachnoid hemorrhage, worst headache of your life. This is what we are looking for, blood in the suprasellar cistern. This is so-called Star of David sign. This should be all just filled with CSF. And then you can sometimes see the blood hyperdensity in the gyri and sulci. And then your intraparenchymal hemorrhages. This is usually caused by hypertension. Favorite locations are the internal capsule, thalamus, and cerebellum. So learning to talk the talk. So we covered this in the RAD path. I just wanted to introduce it here. If you have a lesion coming down hard, solid versus cystic, is it intraaxial or extraaxial? Is there enhancement? Is there edema? So cytotoxic versus vasogenic. Is there mass effect? And looking for those other findings of hemorrhage and hydrocephalus. And this is one of my favorite differentials. When you have a enhancement, ring enhancement, the differential magical doctors. So METs, abscess, GBM, infarct, contusion, AIDS, lymphoma, demyelination, radiation necrosis. So note we have METs and lymphoma on this differential. So every Hartman differential, if you haven't heard me say this yet, METs and lymphoma, common things occur commonly. And my last pearl is that lesions that cross the corpus callosum, be thinking GBM and lymphoma.
Awesome. Thank you so much for that, Dr. Hartman. Now we'll go through some common scenarios. Again, I'm Davin Evanson, doing this video with Dr. Hartman. What I love about these modules is they go through these basic information that you need for your rotation or for your internship. And then they give you these common scenarios or case studies or even questions to go through to test the knowledge and to get that repetition. And I'm currently on my neuro rotation, and I have found this module and even the anatomy modules super helpful. And I've actually been pimped on a couple of these things and been able to get those questions right because of these building block modules. So the first case, and the only case we're going to go through, there's other ones on the module to go check out, is echo trauma. 117-year-old male, unrestrained passenger in an MVC, GCS is 7 with scalp lacerations. So what are we most concerned about here? Definitely head trauma, a bleed, epidural, subdural contusion, or even a fracture, calvarial, skull base, or facial. What tools can we use? We just talked about CT, MRI. There's pros and cons to both of those. Do we use contrast here? What do we order? Non-contrast head CT. Key point here is that it's fast, it's available, and it's sensitive for blood and fractures. So for head trauma, we can look at the Glasgow Coma scale. If you've done trauma, you should be very aware of this. There's moderate to severe impairment where you get the non-contrast CT. There's mild impairment, which is GCS above or equal to 13. What do we do there? There's the Canadian rule, there's New Orleans criteria, and there's the Nexus criteria. We'll talk a little bit about the Nexus criteria here. It's for patients with the GCS 13 to 15 after a witnessed traumatic loss of consciousness. And when is CT necessary here? It's for those who are high risk for neurologic intervention or those for medium risk for brain injury with detection by CT imaging. And this is very sensitive, so something to be very aware of. And then Dr. Hartman talked a little bit about this, but in this case, again, we're worried about an epidural hemorrhage, a subdural hemorrhage, subarachnoid, or intraparenchymal. Again, epidural kind of looks like your lemon. It's going to be those middle meningeal arteries. Subdural, it's going to be your banana. It's going to be those bridging veins. Subarachnoid, it's going to be an aneurysm, worst headache of the life. And intraparenchymal, okay? So those are things to be aware of. Go check out this module. You'll be able to check out other cases, other questions. Again, this was super helpful for me on my neuro rotation. Appreciate Dr. Hartman's time. Thanks for checking this out.